I just also add to this what you've said, Dr. Bukhari, that
Yes, sir.
Nadeem is himself.
Yes, sir,
He's a
Nadeem,
scholar.
yes.
He's an author. He's just published another book. He's also a TV anchor person. He used to run a program on British TV at a peak time called Mind, Body and Soul. Very popular program. He is also the illustrious son of a very illustrious father, Mr. Sab Akhtar, the famous poet of Pakistan. Shair Pakistan.
Very famous poet.
Very famous poet. So thank you, Nadeem, for coming over and giving time. I know you're very busy and you've been traveling lately, but pain is an important subject, and this, I thought, you're the best person to talk about. So over to you now.
Bismillahirrahmanirrahim. Thank you, everyone, and welcome as well. I'm honored to speak on this forum. It's a Saturday, and I want people to be at ease and feel relaxed, because it will be a light-hearted talk. I understand there is a big match going on as well, so I will try to be quick. I would, being a neurologist, I have given a little bit of a flavor to this vast topic of pain. We can talk and talk for hours. So I would limit myself to the neurological perspective, if I may. So let's start. So giving a bit of a perspective to it, and when I was thinking about the topic, there was some spontaneous thought that came to my mind. I thought I should discuss that. I really honestly believe the pain and pleasure are an integral part of a human life. We all know humans seek pleasure and would love to avoid pain, but when we go above in the hierarchy of our existence and meaning of life, it really goes beyond the pain and pleasures and enters the realm of passions and purpose. In my very, very humble opinion, life could never be free of pain. It will be an inevitable part of our being. There will always be some form of pain, whether it's physical, psychological, or emotional. And I believe strongly in this as well, that no purpose in life could be achieved without facing pain. The other aspect, which we would know when I was preparing this talk and I was looking into the mechanisms of the pain, and each time I read science and I go in the context of divine aspects, I feel, and I really feel, that the humans are the masterpiece of an artistic, scientific, divine technology. And when we're going to talk about the pain and its mechanism, we would know that how it's sensed, perceived, and transmitted. We would be amazed that how classic this divine technology is. To me, pain is the creation of God for our growth, survival, and protection of life. And professors are here, and thinkers are there in the audience. Perhaps let me share this as a food for thought, that our growth. So the pain, I say the pain is the creation of God for our growth, survival, and protection of life. Now, if I get a little bit of more perspective, that during the process of evolution, for life to survive on this planet and grow to the present day, it has to have tools of protection. I was giving this talk with some other aspects of life, and I also believe that life is the most intelligent, ongoing phenomenon in this universe. Trillions and trillions of reactions happening every second in trillions and trillions of a body cells is an amazing, intelligent, divine technology. And that life, which I say is the most intelligent phenomenon happening on the surface of this planet, requires intelligent phenomenons to protect it for its growth and survival. So pain is a part of a safety method that is required. Now, so can we define pain? Now, I do see that pain, there are certain feelings that you cannot describe in words. For example, if somebody has never experienced pain, you cannot describe in words. Someone has never tasted a honey, for example, you cannot describe in words what honey tastes like. It's an individual experience. Somebody has never smelled a rose. Can you describe in words? So you cannot. It's an individual phenomenon, but because we have to define it, it's an unpleasant sensory and emotional experience associated with actual or potential tissue damage. So pain is common. We all know. Those who have a medical context and come from medical professions, they know. And even if we are common members of society, we know the pain is a common thing that we see around. It's one of the commonest symptomatology that exists. It is a leading reason for patients seeking medical care, and it's one of the most disabling and costly conditions. Globally, it has been estimated that 1 in 5 adults suffer from pain, and that another 1 in 10 adults are diagnosed with chronic pain each year. The prevalence of chronic pain is about 20 to 30% in Western population. So it's a huge cost as well. So it's at least about 245 billion US dollars lost every year in missed work days just because of pain. So pain is common, pain is expensive. But why? What's the need? Now, everybody would think that what is the need of pain? It is defined, it could be looked in this perspective as well. It's a built-in alarm system that makes us aware that something might be going wrong in our bodies. As I previously said, it is essential for survival. Now imagine, if you pause for a second and imagine that, and this is another perspective, that pain is a form of blessing as well, although it sounds counterintuitive, but it is. So imagine if somebody had a major heart attack without a pain. If someone has an infection of the appendix or the bowels, painless, what's going to happen? What is going to happen is the painless peptic ulcers are there. So the pain is the alarming system which alerts and protects, because if we do get heart attacks without MRs, without pain, and you can imagine if that small percentage went to a higher percentage, then what would be the number of deaths would happen. So pain is helpful. Now, I would be talking about the pain pathways as well, and people with, I know there are people with medical backgrounds and some others are without it, but let's imagine this pathway. So if you have hurt your knee, then there will be a need for us to do something for that painful knee. So the messages needs to be transferred and transmitted from the knee to the brain, right? So there should be highways, there would be tracks, there would be wires to carry that message from your joint or skin or your heart or from your viscera to the brain. So we would talk about, there are what we call ascending pathways, which goes first from the nerves, and I'm going to explain in simple terms and words what the nerves are and how they carry the messages. From the knee, it goes to the spinal cord, the first station, and then the second station from the spinal cord goes into the brain in the thalamus, and then the third and the final the GHQ of brain, which senses and perceives the pain stimuli, is a somatosensory cortex. We're going to talk about it a little bit in perspective of that. So we have senses. So on our skin, we have senses. I'm trying to be simple in my words so that people with non-medical background could also understand. So we have sensors on our skin for pressure, pain, temperature. All these sensors are there. Now, so the pain sensors or the pain receptors, what are they? So we call them nociceptors. They consist of free nerve endings, and I'm going to explain that. So this is just a cartoon image of this, just at the end of a nerve, which senses there is something wrong, something harmful is happening around that region, whether it is mechanical, whether it's chemical, whether there's an infection. This area at the nerve ending, the sensors we have, the nociceptors, would start the process of sensing the stimuli that's happening is basically injurious. So we have ascending pathway. The red one is the ascending pathway, and the blue ones are the descending pathway. I'm going to explain that. Now, to understand that, let me explain. I did say that we try and make it simple for everyone to understand. So this is, I don't know whether you can see that, but this is, let's bring some light to it. So nerves are like wires. As we know, it's simple word that nerves have their, like the electrical wires have the sheets. So the nerves have their covering and they have got the sheets. And if you could see this one, that at the end, so the nerve has got the sheets, and there are fibers inside the nerves, like the electrical wire have the metal core. The nerves, after and underneath the sheet, there are nerve fibers. Nerve fibers are microscopic structures like fibers, as the word explains. They're basically scientifically called axons. Now, if I could, so at the end of these fibers, they are very tiny, they are very microscopic. These are the nerve endings. So these nerve endings have got at their ends these sensors, these pain sensors, the pain receptors, they are there. Now, so this is what I want to say. So these fibers, we have two forms of fibers there. So fibers would carry this message eventually on this nerve to our spinal cord and to the brain. So that is the concept. Now we have got fibers which are a bit thick, like between 1 to 6 micrometers, and they have the sheets, and they are the nerve endings. These fibers, they are the fast tracks. They are the fibers which carry the stimuli, which is injurious, will be carried by these fast fibers first, but then we have C fibers as well, which are smaller in their diameters to about 1 micrometer, right? So, but eventually they would carry from the nerves to the next state. Let's see. Now, before I go that, so these, which I was talking about, these sensors for the pain, we can give an analogy. They are like Watmans. They are the guards at the end of the nerve fibers. For example, if you're talking about this area of our finger, there's a skin. On the skin, there's a nerve, and the nerves have got nerve fibers. On the nerve fibers, we just explained the tiny bits. At the end of that, these receptors are there, the sensors. So they are called the guards. So they are normally inactive. Once they get this stimuli, which is not good for us, is in form of pain, an injury, pressure, an infection, all that, they will be activated. So once they are activated, we know what activates them. So if there's a high temperature, they would be activated. If there's a high pressure, mechanical, they would be activated. If there is something chemically wrong, they would be activated. Now, once they are activated, then, as I say, these neurons send signal as an electrical impulse, that we call them action potential, to other neurons. And once the signal reaches to the dorsal horn of the spinal cord, the spinal cord we all have, the second stage, the second station is there, and then it goes up and goes into our thalamus, and then it goes to our brain. Now, let me give this picture again. So that's where we're traveling. So the red ones are, the pathways that travels from our skin to our arm, then goes to our spinal cord here, which is in our spine, and the spinal cords also have tracks. There are motorways, there are highways. Some of the highways and motorways are taking these messages of the pain of this injury to our spinal cord. We call them spinothalamic tracts. That's a scientific term. And then it goes into our brain. First in the spinal cord, this is the first center. The second one is there in the thalamus. And then right at the top there on the brain surfaces, the cortex, this is an area which reads them. It decodes them that, okay, pain is happening. And there is something that we need to do. And that is why our consciousness get alerted and we do something. Now, we do by thinking and the rest of it, because there's a cognitive response, but there's also the God has given us, Allah has given us the descending pathways to control this pain, and some of the pain perspective get controlled. So we have highways going up and highways going down to the area or the site of injury. Right. Okay. So going further. So are the pain receptors everywhere in the body? Yes, most of it. The skin, the muscles, the blood, vessels, joint, bones, and internal organs all have these sensors and receptors to get the stimuli of something wrong chemically, physically, or thermally. Now, there's an interesting aspect. The brain itself does not have pain receptors. The coverings, the brain coverings, the meninges do have the pain receptors, and that causes it. The brain vessels going to the brain or inside the brain have these sensors, but the brain tissue itself does not have the pain receptors. Now, how many pain receptors do humans have? We have in about a square centimeter of skin, about 200 pain receptors. So you can imagine that, when I was talking about the survival and the growth of the life. So life is, as I say, it's an intelligent phenomenon, and it knows how to protect itself, that the divine technology given to us. If there is a pain, we don't have to think and we move away our hand. If there's anything, so some of the things are beyond our cognitive control. We don't have to think, we have to react because life would like to protect itself. So every square centimeters of our skin contains about 200. This is more than the pain receptors and more than the temperature receptors. So that's the importance of the pain. Now, when I in the beginning I said that the life is a highly intelligent phenomenon, and trillions of reactions are happening just in 1 second to maintain life. And similarly, I was talking about this small area has so many receptors, and you see that trillions of the small print all tells us that what are the electrical and mechanical reactions and processes are happening quickly within a fraction of seconds to get this message to come across to our brain. Phenomenal. And the electron exchanges and the sodium coming in, the potassium going out, all these reactions are happening in a fraction of a second. So that's why I say it's an ultimate, the humans are really an ultimate piece of scientific art. Now, how to measure the pain? Now, we have different scales, and we have numeric rating scales, and I obviously, when I'm being a neurologist, when I generally use that 0 to 10 rating, and a 0 no pain, and the 10 being the worst pain possible. It's easier. People who have cognitive intact, they're conscious, they're alert, and they have mental abilities could grade them. But then there are people, for example, the young children. I don't work with children, but people could use a visual analog as well. People who have limited or learning disabilities can also use that. So that's the perspective of the pain, why we need pain, how the pain is so important, what is the mechanism behind it, what are the pathways that help. Because I have made this talk in a bit of a neurological perspective. I'm not a pain specialist, and in England we have a specialist training for people who lead the pain clinics, and it's a minefield on its own. So I don't normally deal pain as such, although obviously being a neurologist I have to deal with neuralgias, and I have to manage patients with headaches. So I would give a little context to that. Now, let's talk about the neuralgia. So this trigeminal neuralgia. So people obviously, as I say, people here with medical background, and some of them are not, but it could be useful for them to know. So apparently, so neuralgias are short-lasting, stabbing, intense pain. Whenever it's a very short-lasting, electric shock-like, lasts for a second, but it gives an ouch, is what we call neuralgia. It's a pain because of the nerves. Now, trigeminal neuralgia is because we get the trigeminal nerve involved. So I will be talking about a few pain as neuralgia which affects the face mainly. So we have 12 cranial nerves, like 12 wires, so to speak, covering each side of our face. So for smell, so for vision, number two being the optic nerve. So it's just a wire. So wire to see an image, we have this optic nerve. So we have names to them. So for 12 cranial nerves, 12 wires. So the wire number 5, called trigeminal nerve, which supplies our face, and it is something that I come across fairly commonly. People come to me with this symptom, which is an electric shock-like sensation happening on the face. So it could be, there are 3 branches to this nerve. We call, here is the ophthalmic branch. This one is the maxillary branch, and there one is the mandibular branch. So each wire has further branches, and it can be in any either or all of the branches of the trigeminal nerve. But the symptoms are that I get, so doctor, I get this dense electric shock like happening like that. And it can be triggered by eating, talking, a feeling of exposure to the cold wind, and it causes that. So we can it's easy. It's not a rocket science. So this distribution, short lasting. This is trigeminal nerve. Now we do the scans. Make sure you're wondering why. It can happen without any obvious reason. For example, we do the scans and find that the brain is fine, the nerve looking fine, but still happening. So it's the hypersensitivity of the nerves at times happen. Occasionally we find reasons that the nerve, the electrical wire, is compressed by something like a vascular loop, or sometimes some serious stuff like tumors can also do that. So we do the scan. Now another form of the neuralgia is around this region. So it's not the face, it's around this region, and we call it auriculotemporal neuralgia. It is infrequent, and if you don't know, even the neurologists and the physicians don't know about this, they call it, it might be stress, or somebody is psychosomatic, and that's why the pain is happening. So this location around the temple region, and again, it is an excruciating, short-lasting, for seconds pain, which happens around this. And it is unilateral. One important thing is it's one side, not the both sides. So I try to be quick so that the supraorbital neuralgias, again, the branches, they can complain of the pain around the eyebrows, and it is, again, could be very painful, pain, shock-like sensations. So distribution of these pain gives us idea that what could it be, or what form of neuralgia it is. Now, the last one on this note is occipital neuralgia. Again, people get the pain. Oh, I get this pain around my back of the neck, and again, if the physicians are not aware of this, it can be ignored or missed. So it is also because the occipital neuralgia is because of the occipital nerve coming out from there, and it gives, again, sometimes it's short-lived and sometimes could be constant. Now, moving on to painful neuropathy. So we have covered the pain, what is pain, why it's necessary, what is the mechanism of the pain, how the pain receptor works, how it carried to our brain, and then we talked about the neuralgias. Now, I will talk a little bit about how we treat these neuralgias after this. So I was talking about the face painful conditions. Now we could have the nerves affected in our arms and legs. So as I previously said, I know some people have joined. Nerves are like wires. The wires have got the sheets and the metal core inside, with the fibers there at the end, with the receptors there. Now, so nerves, there are small wires in our face, but there are longer wires in our arms and legs. And these are the longer wires running our arms and legs, are called, obviously, these are called peripheral nerves, long wires. Now, they can give also pain, and we call them neuropathic pain. So the painful neuropathies are, so not all nerve damage causes the pain, but some of the painless as well. But the ones which these wires in our arms and legs of diabetes. So after, if the diabetes is there for years and years, the nerves are bound to be affected. And it's called a diabetic neuropathy. People with alcohol got this painful neuropathy. So they come up with the symptoms of the nerve problems. It's just not the pain, but there are other symptoms that comes as well. That is the numbness, pins and needles, paresthesias, hypersensitivity to touch, where the nerves are affected. These are the symptoms that would be there in the history. Now, the other thing is a radiculopathy. Radiculopathy is the small nerve roots coming out from our spine. So there are some nerve roots from there, and in between the vertebra. If the disc compresses the nerve, we call it radiculopathy. That also gives the pain. Then I'm leaving bits. There are other areas people have strokes, can have the pain, and spinal cord injury, all that can cause. Now, how do we treat? So we need different medications that can be used, and most of it that we use for the control of neuropathic pains or neuralgias are anti-epileptics. So we use carbamazepine. I don't personally use carbamazepine unless it's a trigeminal neuralgia. it is the tablet. This is the medication for trigeminal neuralgia, and it's most of the time it helps very effectively to control the trigeminal. It might not be useful for the other neuropathies or neuralgias, but somehow it works. We don't exactly know the mechanism. There are certain other anti-epileptics, which is, you must be wondering, oh, this is epilepsy tablet, but why we are using for the control of pain? But we do, because it works on those pain receptors at a the scope of explaining that is beyond the scope of the limited talk. So we use anti-epileptics. I personally don't use phenytoin, although we can be because of side effects. We could use gabapentin, and then we can have other surgical methods for methods of treating. Now, just very few slides for the headache. As I said, if I'm here as a neurologist and we're talking about the pain, then we have to talk about the headaches. I can't resist to talk about that because it could be helpful. Now, the pain is there, as I said, for a long time, and it's a part of our survival. So we know people recognized it. So headaches, again, is one of the commonest symptoms that, excuse me, to the referral to the neurologist. So along with the pain, paresthesias, and the other common reason of referral to neurology. So 1 out of 5 patients that have been referred to outpatient neurology in the UK have a symptom of headache. It's been there, as I say, people from ancient times did recognize headache. It was there even, 7,000 BC, where people thought there was splits causing the headaches. Now, Hippocrates was, the migraine is something that we see, and you know how common that it is. And Hippocrates, the intelligent man in the history, recognized that a shining light into the eyes can cause pain in the temples. The concept of photosensitivity, the dislike for the lights that people develop along with the migraine headaches. Migraine headaches are generally unilateral. It could be bilateral as well, but the typical feature is that they get dislike for the lights and sounds. A bright light would hurt, a loud sound would hurt, and they prefer a dark room. Now, as I say, it's the commonest thing. Headaches is quite common. And as I say, admissions, not just the outpatients referral, but the admissions in the hospitals are also there. Now, before I go further on that, I just define very simply that the serious headaches and the non-serious headaches. For medical professional and the otherwise, anything which starts the headache, which is serious for us, which should be taken seriously in form of headaches, sudden onset severe headaches. This is a thunderclap headache, I'm going to say. So if someone says that I got a headache which got worse within 6, like that, as if somebody is hit with a strong thing on the head. That is what we call a thunderclap headache, and it's a serious one. So, as I previously described, on a scale of 1 to 10, the 10 being the most severe headache. So, if someone says within few seconds, or I got a worst headache of my life, that is a thunderclap headache, and I describe this as a serious headache. Any headache with a deficit, somebody getting weaker in arms or losing the sight, is a serious headache. People losing the consciousness, fainting, patient with the seizures or a fit with the headache is a serious headache. As I said, the visual loss. Anybody with fever or a weight loss, excuse me, is also a serious form of headache. So, as I said, within 60 seconds, the headache speaks. This is something. So everyone, medical or non-medical, should keep this in mind, that severe headaches are serious headaches, and it can happen because of serious things. Obviously, I have to limit myself there and move on to the psychological context of pain. Now, The chronic pain, as I say, it's people who just have, for various reasons, the lower back pain or other areas. So there is, I was looking into that, there's a different threshold for pain. And we see, and you must have experienced, there are people who have a low threshold for pain, meaning they are constantly complaining of pain and having pain, just not complaining that. So there must be something that's, some humans and some races have more threshold to pain, the others have less. And there's estimated whites have more painful experience than others. And there is a theory that, when we're talking about the highways that move from, a spinal cord to our brain, and then there are ascending pathways, the highways getting messages to our the primary area of the brain, somatosensory cortex, which perceives the pain, and then the descending pathways that modulate the pain, calms it down, and then it's a minefield, it's a research, and as I say, they say there is a disbalance between these the pain facilitation and the inhibition. So there's an imbalance there which causes this change. Now, this is what I see when people come to me with symptoms of pain, and just not pain, and sometimes people have other symptoms as well, and we do all the tests and we find nothing, but they are worried. They're worried and they're fearful. And this is important to know, that whenever there is something unexplained, there is a fear. And they say the fear of undiscovered structural damage is common. About 44% say that if they have pain, there must be something wrong, which is not always true, obviously, because of various aspects that we have talked about. And the other thing I observed, and you must have observed in your life, the people have pain, they have other features, meaning they are more likely to be depressed, and they are more likely to have anxiety as well. So pain is just not, if it becomes chronic pain, it is just not the symptom of pain, it becomes a syndrome affecting the mind in a way of causing anxiety and depression and personality changes. So there is an aspect when the thresholds are not right, when we do not have our coping mechanisms for pain, then, and it becomes chronic, then it will have an impact on the mind as well. So I think I'm just about to finish. So pain in the context of spirituality, this was, now this is interesting. It's very, and I find it interesting that the pain and the fear, and they say they would never go away. It will always be fear. So there is a saying in America, they say, feel the fear, but do it anyway. So the pain and fear is for our survival, and maybe a topic somewhere, maybe today, why they become integrated in our human psychology and our integral part of our thinking. So what I wanted to say that there are religions, there are traditions where people say the pain could be a form of, if they expose themselves, in Hindu religion, there's a form of tapasya, for example, and they expose themselves to the pain, and we know the famous Buddha, very intriguing figure. If you go beyond our religions, found, thinking openly that he when he was looking for nirvana, the enlightenment, he left the palace, and we know the story. He was young, he was a prince, but he wanted to know the meaning of the life, the real meaning of the life. So he wanted to know the answers, and he exposed himself to the pain as well. He was thinking that if this painful meditation or ritual would help him get the answers of this truth and enlightenment. And no, he exposed for hunger, and he used to do other. Eventually, he did meditate underneath a fig tree, and those 6 nights and 6 days was there when he was under the fig tree and thinking and meditating, and got the answers of enlightenment, so to speak, in their perspective. Now, I did this is the final bit of my slide and of my talk, that the concept of pain has been used by the religion and the Quran as well. So we know that pain, along with other psychological tools, it does influence human mind. And the concept of the psychological tool of the reward and the punishment, the heaven and the hell. Now, there was an interesting thing that crossed my mind. The concept of punishment in the hell is utilizing the tool of the extreme pain. So the human behavior to be directed in the right path, there is a concept of a hell. And if there is a concept of hell, if you look in the broader context of the hell, there is a concept of extreme pain. And it's rather interesting. If you remove the concept of pain from the hell, then how would one think? So this is a food for thought. And I think that a number of things that we could discuss, but I know this is perhaps a time to say thank you. I end here. If anyone has questions or comments, I'm happy to answer.
Nadeem, it was an excellent talk, and you've covered all the aspects of pain. Pain, as we've all experienced at one time or the other, is an excruciating experience, very unpleasant. I have one question. I was reading through a paper recently for a book that we're compiling on palliative care, and one of the measurements they use of palliative care physicians is called Socrates. Have you heard of it?
Yes. So yes, this is a mnemonic used for the evaluation of the pain, and the medical students use that. So it talks about the site, the onset, and the rest of reaction about it. So yes, I've heard of it. But as the palliative care is a specialized area.
Yes.
Expertise of different times needed. Yes.
Right. The other thing is that your comment about spirituality, also a wonderful article I recently read. It was presented in Iran at a conference on spirituality and the role of biochemistry in the brain.
Yes.
And you might have heard this gentleman is in Oxford. I can't remember, is in Dahlia. He's done doctorate on the role of spirituality in healing, where he did the EEGs and MR scans and found in a control group who did not do spirituality or soothsaying or whatever, compared to the ones who were doing, it was more relaxing. The EEG pattern was different than the ones who were not doing it. Any comment on that?
Oh yeah, thank you for that. Yes, I mean we have it's a minefield. I mean, when we do meditation, the meditation has got, no, it is beyond religion. You know, we can talk about istaghraq, we can talk about wajd, we talk of hal. All these words describe that trance like states that are required, whether you're offering namaz and you are distracted from time, place, and person, even yourself, and you get into that zone. And when you get into that zone, a lot happens in our brain. The brainwave patterns changes. So all of us now have a fast brainwaves traveling like that because it's a thinking fight and flight mode. But when we go into trance, these waves get slower and slower, and we get a powerful waves, so-called the alpha waves and the theta waves. And when we get that zone, because of spirituality or this trance-like state, waves pattern change. We know that. So this is for the fact, the people who meditate that. Now, once you change that, now a number of things happen. One is that our prefrontal cortex, which is the box of logic that keeps under logic and keeps about facts and does not let our other intelligent areas to share ideas, is quietened. And that's why, and it's just not that, our amygdala, the anxiety, the centers are calmed down. And the whole, the neurochemical profile changes from excitatory to more relaxing chemicals. So, and that helps with healing. And the transformation just not happens just in the brain, it transcends into our body. And they say, you know, there's a saying that I like a lot, that be careful what you say when you're being asked, how do you feel? Because your cells are listening. Cells do listen, it's not a metaphor. Cells are listening. The way we think, there are genetic studies about the size of a telomerase, the DNA part, which helps in replication of the cells and for the health. And we know people who are stressed have smaller sizes of telomerase. So that we are stressed, we think the sizes of the telomerase, the part of the DNA which helps in replication gets shorter. The shorter you have, the more complications you have, more conditions you're prone to. The bigger it is, the more healthier you are and the healing happens. So yeah, amazing.
The spirituality. You know, all the time in the day we become tired, and if we walk more or we get more pain, aches in the body. And when we sleep, I think we feel something better. Same as the spirituality and and poetry or something, listening Quran or something else. As with you, we are member of the Arbabe school in our group. Is it all chemical mediators released from our neuro nucleus, or some dopamine or something else? What can you explain this thing?
So the thing that you are, so this, the book that I've recently written, have covered bits of it. It's because the neuroscience in the last 10 years has given us so much which was not there the last decade, so which was not there for centuries. So now we know much that when we think of, you know, spirituality or faith and faith healing, all these have a scientific evidence now. So there is a phenomenon.
Yes.
There is a phenomenon. There is a phenomenon they call a deep relaxation state without sleep. So you're awake, but you have the same serenity as if you're asleep. And yes, there are a number of chemicals. I call them precious pearls, like dopamine you mentioned, and these precious pearls are being misdirected. So this dopamine, when we wake up in the morning, dopamine is fresh from the farm. Now, from first hour of our awakening, whether it goes to all the worries and fears and all that, or the chemicals, the neurotransmitter you mentioned, such as dopamine, will be utilized. Where you're utilizing it, in which part of your brain makes you different. So if you are directing in the peaceful, activating those spiritual areas, so to speak, in the brain, or the areas of serenity, that way will help us.
Thank you. Dr. Rashid, you have a question? Professor Rashid, you have a question?
Assalamu alaikum, sir.
Walaikum salam.
Hello?
Yes,
sir.
we're hearing.
Right. There are some areas in the body which are said to be pain insensitive. Can you name them? Are there any viscera in the body which are, don't have any pain receptors?
Well, yeah, I mean, the brain itself. So, although the brain, the master controller, which is on a light note, I'm saying the GHQ is sensing the whole body's transmissions are getting there, but itself does not have pain receptors. So, yeah, interesting.
Dr. Nadeem, I have one other question from someone else. If I
Yes.
am not a doctor and I do not know about my coronary arteries, and the death due to this stoppage of coronary artery is due to severe pain or due to ischemia?
Right. Okay. So it's a cardiologist to be, but I think I cardiologist. Pain. Okay. There is an interesting undertone to this question. I'll try and answer that both. So the simple and short answer is the pain is a consequence. It's concept of a chicken and egg. So which one first? So the pain is an alarming signal that something is not right about your heart, right? So pain is a consequence rather than the cause. Now, having said that, now some people, which is a very, very, very exceedingly rare, if the pain is so intense that people could die because of fear of pain itself or overwhelming, but that's exceedingly rare. The simple answer that pain is a consequence of the blockage to the coronary artery rather than the cause of death.
Over to you, Dr. Mubashir.
Thank you, sir. I think that ends our session today. Thank you, Dr. Nadeem Akhtar, for such a wonderful elaboration of the topic pain management, and Professor Mulazim Hussain Bukhari Sahab for helping us out, and Professor Shabi Haider Zaidi. Thank you all for joining for today's session. Hopefully, you will all join for our upcoming next webinar on the next Saturday at the same time.
Can I, Dr. Mubashir, request Dr. Nadeem एक शेर पढ़ दें, because he is also member of our Bazme Sukoon and
गालिब का इसी हवाले से गालिब
yes,
को चचा गालिब कहा जाता है, and I was thinking चचा गालिब क्यों कहा जाता है, and we can all relate to him, so we can call him uncle. So गालिब का ये शेर कि इन आबलों से पाँव के घबरा गया था मैं. When I saw the blister in the sole of my foot, I was worried. इन आबलों से पाँव के घबरा गया था मैं, जी खुश हुआ है राह को पुरखार देखकर. I saw on the pathway there are thorns. I know this is the solution. So इन आबलों से पाँव के घबरा गया था मैं, जी खुश हुआ है राह को पुरखार देखकर.
Wow. So much depth in it. Ghalib is Ghalib. You can't beat him.
yes,
Very
sir.
nice, sir.
Thank
you
you,
all.
Nadeem.
Thank you
so
all.
much.
Thank you
Most
very much.
grateful, Nadeem. Thank you.
Allah Hafiz.
Shukriya, Janab. Allah Hafiz.